You could see this?
Yes, sir.
Yeah, Satya. Okay. Good morning, everybody. Good morning, Shiva, Dr. Bharat, Saurav. It was a nice talk. Dr. Nageshwar Rao, KK, everybody. Okay, most of the things have been covered about the assessment by Saurav. I'm sure yesterday it must have been spoken by Dr. Radha also. So what we need to see, of course, most of the things probably are important prior to the transcatheter device closure. Assessment of the patient symptoms, majority of the asymptomatic functional class, associated comorbidities. History of any RV dysfunction is quite important. The assessment and the non-invasive echo show the RV function. No excessive desaturation, other evidence of pulmonary hypertension clinically, ECG and echo wise. Assessment of the defect is already been done. So what are the ASDs that can be closed with the device? The majority, almost always, is secondary ASDs and some sinus venosus ASDs, where let me confess that I do not have any experience of closure of the sinus venosus ASDs. Shiva has quite a good number of cases. What are the different access, different approaches? This is quite important. The standard practice, I mean, 99% of our more than that is a femoral access, femoral venous access, jugular when there is IVC interruption. That we need to know that, and we have done a couple of them. And transhepatic, extremely rare, but I don't have any experience, but I would just borrow some of the slides from Dr. Nageshwar Rao. And the procedure without fluoroscopy, once again, I do not have any experience, but it is being done by Dr. Krishnamurthy in India, in Chitra, and Dr. Pan from China. So the pre-procedure, informed consent, of course, is extremely important. I think a lot of stress was given yesterday about counseling, consent yesterday. In case of difficult ASD counseling regarding the chances of failure, this could be there. Though off late, this is extremely low. Informing surgeons and the blood products to be kept instant if anticipating some difficulties, making sure that cath lab has all the necessary devices and the delivery sheets on the shelf. The aspirin, the night procedures, once again, it depends on the institution policy that to give the pre-loaded, majority of us preloaded. Large defects in adults, safe to give 1 dose of IV furosemide the night prior. If you are suspecting that person might be having a diastolic dysfunction, a hypertensive heart disease. Anesthesia, sedation in children is a must. If procedure is planned under TE, needs intubation in a younger age group, and a conscious sedation is quite good enough with a propofol in older people. Of course, nowadays the intubation is very, very less because the procedure time is extremely low nowadays. So unless you are a complicated ASD. The access, femoral venous access in majority of our cases, dual venous access and both bilateral femoral is needed in patients who require a balloon or a wire support, or areas possibly when you are assessing the patients for the operable hemodynamics where we need to close or not. So we can balloon occlude the ASTs and see whether it is operable or not. The arterial access of the planned CAG is to be done in adult patients or to record the LVEDP many times. You don't need this pre-procedure, but the post-procedure, better to have in older people when you have anticipating this kind of a problem, where you're planning a CAG, the arterial access, maybe 4F or 5F, from the radial, good enough. Hemodynamics is important. I think in every case of a ASD, the pulmonary artery pressure has to be recorded. The samples can be taken to calculate QP case, but it is not really often done. But as a protocol for the younger generation, I think you should keep doing so that we keep in touch with our the cardiac catheterization techniques. The baseline LVEDP in patients with severe hypertension, diastolic heart failure, and the balloon occlusion in borderline hemodynamics. I told you about that. The most important, I'll tell you, the safety, because this particular procedure could be the first time, and it should be the last procedure for that particular patient. That's why the safety of this particular procedure is extremely important. Know your limitations. Saurav said that initial stages, we should not take up all kinds of ASDs where possibly we might fail because of the large defects, deficient rims, unless we have a correct knowledge, unless we have a lot of experience with that. So I don't think we should take on these cases unnecessarily, because this could cause a damage, prolong the procedure. A lot of things can happen. Do not forget that there is an alternative to this procedure, which is a time-tested one, which is a surgical closure of the ASTs. Almost, I can say, in majority of the center, the mortality and morbidity should be less than, it is 0%, approaching 0%. Complications do occur, though they are very less. The various complications, a simple complication like the air embolism. It can be simple or it can be fatal. So embolization, perforations, all these two things happen, or the compression on the left circumflex artery, causing a heart block. These are all not unknown. This could happen during our practice time. It can happen. The device size is almost pre-decided prior taking to the patient on the table, either on the transthoracic and the children. On the transphalangeal, as a policy in adult patients, unless it's a very simple centrally located ASD, as a moderate size ASD, majority of the adults, we perform transvaginal. Once again, it depends on the institution to institution. But in children, majority of the children in the small age group, less than 15 kilos or 16 kilos, a simple transthoracic echo during the procedure is quite good. Using the sizing balloon and measuring the indentation, it is slightly almost given up in majority of the centers, unless we are not doing a TE in some centers. TE is not available or TE is not being done, or we can use this still. That particular procedure is still a useful. A lot of centers do this particular procedure even today. So don't give up that particular procedure. Have that some idea. The long sheets, a lot of material, like the hardware we need to do. Most important is the sheets, introducer sheets, Mullins, LifeTech, Senju, various sheets are available. Personally, I feel that we stick to in our center the Mullins sheets. They're good because most important is they're soft, unbraided, easy to manipulate into the pulmonary veins, into the LA. And also this side arm, the port is excellent, especially if you're using even once or twice, you can use the sheets without having any area embolism. LifeTech, they're good, rigid, braided sheets and steady. The one problem I face is that ASX the side port is not a very good one. So the Mullins sheet is a very standard one. Most of us, I think my colleagues also sitting there, they agree that the Mullins sheets are good. We can use any sheets, but only thing is that we need to take care of enough precautions. The de-airing technique, this is the most important thing. Of all the problems, what we faced during the ASD closures, used to have the problem of the airing problems. So air embolisms. IVC was pulmonary vein. So some people like me, we de-air in the IVC. Take a sheath and remove the dilator, keep the sheath in the IVC and de-air it. And over the most of the large ASDs, you can just pass these sheaths without any problem into the LA or pulmonary vein. IVC is a large result, less chance of embolism, and you can take it out. The pulmonary vein, air can be sucked in through the hemostatic valve, so be careful with that. There are various things or maneuvers can be adopted, like slow removal of the dilator with a wire to wires vacuum, dripping the wet gauze at the sheath valve, and let the sheath back bleed under water seals. The good old technique instead of flushing will reduce the chance of air embolism. I think this is the most important. Spend time, doesn't matter, 3 minutes, 5 minutes, do this. This is a wonderful thing we need to take care. The deployment techniques, a very classical approach. Put a sheath into the LA and load the device and open in the left atrium and come back and either the transthoracic or a TE, use that imaging technique to standard. And 95% of the ASDs can be closed if our assessment of the ASD size is okay. We can do just this a classical approach. The LVP approach, RVP approach, appendage approach, LA loop approach, and the most important is a balloon assisted technique. Still, we do come across of utility of this particular procedure. Very nicely, it is demonstrated in the initial days by our own Dr. Bharat Dalvi. A lot of papers on this. I think we should give this kudos to Dr. Dalvi for engineering this particular technique and popularizing this technique. Even today, I think this technique is a wonderful technique in some cases. The Minnesota legal to confirm the capture of the ribs. So some of the, we'll go back to the case, some of the cases. This is the sheath is in the left atrium. So make sure that as a policy, some people, we just floor this C to C, make sure that there is no air. In a good fluoroscopy, we can avoid, if you just spend maybe about 10 seconds, the fluoroscopy may be extra, but make sure that there is no. This is a very classical technique. So you see the left bronchus. The left bronchus is in the area where the left atrium is there. So open the left atrial disc. Is once again this relooping the same thing. Of course, this has to be under TE or transthoracic. So deploy the left atrial disc and come, and you get some kind of resistance in the right atrial area. So oppose it nicely. So if you get this particular in the fluoroscopy, that means almost you can say 99% of the times you're okay. So the large ASD where we have a problem with the deficient rims. So many rims, IVC rim, I think Sir spoke about that, IVC rims, and partly the posterior rims, aortic rim, majority of the cases, aortic rim would be deficient. So if you have a large ASD with the deficient rims, as standard, the classical approach may not work. So you use the anchor, the left atrial disc, either in the left upper pulmonary vein or the right upper pulmonary vein, and the device is partially open in the pulmonary vein, and just anchor it and come up to the ASD, and then so make the ASD the right atrial disc opposed to the septum area, that ASD area, and then either you have to use, you should not pull it many times. That will be always propagates that you push and make a loop on that. It will come back, the left atrial will come back and sit in the left atrial disc area. So this is the right upper pulmonary vein technique. So here many times you have find, so this is very not uncommon situation. We have deployed, it is not, doesn't come many times easily, and it is not widely advocated in each and every case, because we have some cases of perforation of the pulmonary vein, and you can never do about it. So this works sometimes, but it is not a very, not without any particular issues. So the wire and balloon assisted technique, large ASD with a deficient AV. Similarly, what I told you about the right upper pulmonary vein, similarly you can anchor the left atrial in the left pulmonary left pulmonary upper pulmonary vein, and you can do the same thing. The large ASDs with the deficient AV rims, anterosuperior rim, or the posterior rims. The stiff wire is placed, even the wire is good enough. Even the Dr. Krishnamurthy uses the dilator, the septal dilator, just basically to make the prolapse of the left atrial disc into this ASD defect. So it will definitely give some kind of a fulcrum. The stiff wire is passed from the other femoral axis across the ASD and the parked in any of the pulmonary veins, depending on the different rims. This wire itself could stent the septum at the deficient rim. It helps in the device deployment. Once the RA disc is also deployed, the wire is removed and slowly, without disturbing the device orientation. So this is from the right femoral vein. Enter, park the wire, enter the right pulmonary vein, and use the balloon. Either way it could be done. So right now we don't get very often, it's not very easy to get those spherical balloons. We use these sizing balloons. They work easily in a good manner. Basically, we need this balloon, whatever the shape of the balloon, basically to make that, to avoid the prolapse of the left atrial disc and give this fulcrum to the septum. So similarly, so many times in order to avoid, what I do is that I don't open entirely into the right pulmonary vein. So even when you have a balloon, even just at the mouth of the right pulmonary vein, even if it open it up, use the balloon support and then deploy it. That's good enough. So I don't have the picture of from the left upper pulmonary vein. You could miss it. So these are all the various similar things. So this is the balloon is in the right pulmonary vein. This could work many times. Okay. This is just to illustrate. I just partially opened near the LA appendage, and this is once again, don't underestimate the LA appendage anatomy. So this is the standard of the pulmonary vein techniques, LA appendage technique. I don't have a here of the LA roof technique. So many times you can just manipulate this your the sheath with the device here and there. Orientation, as Saurav was telling, is quite important in placing this device. ASD device in interrupted IVC, jugular access. So when is the IVC interruption is there, this is not very difficult. Get the jugular access. Use a TE, because we are not routinely oriented to place the device or to deploy the device. The moment you put a wire, the whole sheath enters the LV. You could see that. So this needs a little bit of understanding on the TE. You need to have a TE, because you have to open the device there in the near the metal area. Come back, you see. And whatever couple of them I have done, these are all not very large ASDs where jugular approach is needed. Maybe I was lucky enough to get this kind of a moderate size or moderately large ASDs. I do not know because I have not had any great experience with the large ASDs where the IVC interruption is there when I was forced to do this. So once you do that, I mean, preferably the T is definitely most necessary. Transhepatic approach. Courtesy Dr. Nageshwar Rao morning sent me. I think this child had a IVC interruption, IVC obstruction. Okay, and he said, I asked him why you did not do from the jugular approach. He said that it's a posterior rim is deficient, so he resorted to the transhepatic approach. So for this, I think we have to have some experience of maybe align with the radiologist to get the access and the ultrasound guidance and put a sheath, few choice, whatever is necessary, and then deploy the device. So it's a wonderful procedure what he has done. Not to be attempted in each and every unless we have a good experience of a transhepatic thing, where we do have experience of transhepatic puncturing of hepatic veins for the Budd-Chiari syndrome, not for the ASDs. I have never done that. The after deployment, a careful assessment on the echo key in adults, confirming the position of the device, the TT and the TE, LVDP remaining within normal limits for adult patients, and sinus rhythm should be maintained, because many times we do come across the atrial premature contractions, atrial fibrillation, all these things we need to sort out the rhythm problems. This is how it looks like. So if you have this picture like this, you should be happy with that. So you see, this is the most important thing. After the procedure, have this particular 40 to 50 degree angulation where it has to splay and cross the aortic thing. Unless you have that, you cannot release the device. Don't release the device because it can embolize many times. This is make sure that the mitral valve is okay. Okay, the SVC limit is caught. Then no mitral regurgitation. The post-procedure, large sheaths might require a small stitch, or you can just a figure of 8 extubation in case if you have intubated on the table. Majority of it can be extubated. Patient who had a large defects might need observation ICU overnight and with IV furosemide. Dual antiplatelet in a large defect, where we have put, it is a policy in adult patients with we have put a more than 30 millimeter device, the dual antiplatelets. ECG demonstrated in the sinus system. Take home message, assessment of the patient in and to along the effect, counseling regarding complications, though there may be some small complication is necessary many times, planning the procedure on the day prior, awareness of various techniques, and follow up of the patient through procedure. Thank you very much. Satya?
You hear me?
Satya?
Hello, can you hear me, Jay?
Yeah, Shiva.
Yes.
Shiva, I can hear. I can hear.
That was an excellent talk on all the techniques you highlighted, the entire step starting from the initial vascular access to heparinization. Thanks for the nice talk. Some of the questions that came up. Dr. Srinivas asked a question. There is a US FDA recommendation that retroaortic margin of less than 5 millimeters should not be considered for ASD device closures. So your thought processes on it. I'm sure Srinivas himself will have a very clear thought about this, but Jay Ranganath.
Shiva, I think I'm aware of this particular issue. FDA is 5 millimeter. If you see a cohort of patients of a large ASDs where we in our practice, majority of them will have definitely less than 5 millimeter, maybe 5 millimeter. So I think they're talking about possibly some kind of an erosion and so many issues. But I don't know, the long-term studies have not, in our own experience, have not shown any major issues. What's your thought on that?
In fact, one of this was answered by Dr. Saurav in his slide that he showed from Kodnar's study, wherein more than about 40 to 45% of the patients had a deficient retroaortic.
Yes, yeah, almost 50% will have a deficient rim of the aortic rim.
And it's now also recognized that more than 80% of the atrial septal defects around the world are getting closed by device closure. So obviously, a fair number of patients with deficient retroaortic anterosuperior margins are getting into the interventional subgroup. I'm sure there is going to be, everybody will carefully introspect and look carefully at their results. There was a question from Prem Alva and Abhishek. you spoke about left upper pulmonary vein, you spoke about right upper pulmonary vein, and you spoke about LA roof. Is it randomly chosen or is it on specified reasons?
No, definitely not randomly chosen. In a very standard, if your size is quite adequate, if the rims are okay, no need to do all these things. If basically, as Saurav also said, in a T, he showed clearly there is a prolapse in one of these things. So if you have a large defect, more than 30, 32 millimeter, where very standard, I mean, I still go with a classical approach. I would not go to the right pulmonary vein or the left pulmonary vein electively in majority of the cases. I would still go to the classical approach. If it doesn't work, the T will be on the line. If there is an IVC deficient rim or a posterior rim is a bit slightly deficient, I would choose this one of the right pulmonary vein or left pulmonary vein. But as a policy, I would not go straight away electively. I will not go with these RVPV technique or LVPV technique, but I'll give a try at least once with a regular classical approach, which is a very time-tested one or a safe one.
Well, I'm sure majority of the participants will agree to this view that an initial trial can be made with a standard classical approach, but we also will agree that whenever the ASD device is larger than say 36 or so, especially when you are venturing on to devices more than 42, 44, it is, as you had mentioned, the first go is the best go. And so it may be advisable to choose an assisted technique. Assisted technique means either one of the special techniques that you were advising. There was a question from Dr. Prabhat Kumar about what is your protocol on flimsy rims and some intervening flimsy tissues.
No, flimsy rim I would definitely take into the consideration. If they're very flimsy, I will add into the size of the ASD, which I would like to do that. For example, if the ASD, real ASD is measuring around 16 millimeter, there is a flimsy rim of 4 to 6 millimeter. In adult, really, it doesn't matter. I will include that particular thing. In a child, I think you should be very careful in adding that rim because it adds to the size of the defect, isn't it? So I think the flimsy rim in adult, I think, the flimsy rim means how far it is flimsy. What is the thickness of the particular rim? That is very important once again. If it is too flimsy, I think we should add into the device size.
True. There is also a question from Dr. Srinivas again about the removal of dilator in the inferior vena cava and taking the sheet over the wire all the way up. A couple of points. Number one is when you are removing the dilator in the inferior vena cava and taking one with the sheet, we should ensure that the sheet's rough edges are not going to be carrying the rims of the atrial septum and stretching it all the way towards the pulmonary vein orifice and causing some amount of damage. There was also another concern raised by Srinivas that if we start focusing on the device right from the bottom and not concentrating on the tip of the sheath, we may be we may lose, like we may fail to observe a few air bubbles that already would have crossed and entered into the pulmonary veins and into the left atrium. So he was mentioning to fluoro the device right from the abdomen all the way into the left atrium, rather than focusing on the left atrial sheath as you are pushing the device and keep watching that. I think it makes sense. I think there may not be a very clear answers for this.
No, I mean, okay. Shall I answer that?
Yeah,
yeah. The first question is that a ragged edge is very common when you are using a used particular the autoclaved sheaths. So we should be very careful. In fact, even if it is a minor ragging is there, I would not like to use that particular sheath even for a routine electively also. That I agree with that. We should be having that side. We should not use those ragged particular sheets, especially at the end of.
It's not a question of ragged sheets. It's actually a 14 French sheet that you are taking over a 035 wire all the way up. It is going to have a sizable, large orifice with a lot of free space around. So that I think may be of some concern in some of the...
No, this is possible. This particular maneuver is only possible, I would say, in my experience, only with a proper good Mullin sheet, the blue sheets, not with the LifeTech, because LifeTech sheets and all are very difficult because that we cannot remove the dilator in the IVC because a lot of air will suck into their side port. So I would not do that. The second part of the not concentrating on the LA side, I think that's important. But when I have de-geared in the IVC, I'm pretty sure, I'm very confident, especially in a very good, nice Mullin sheath with a very good side port, that kind of a air embolism is highly unlikely.
Okay. There was a lot of questions on the balloon-assisted technique. Dr. Nilesh, Arun, Neeraj Agarwal, what balloon is used? You already mentioned.
No, I use a sizing balloon. I use a
sizing balloons. There are
also, I use two types of balloons, Shiva. One is a sizing balloon if it is available. Another is that we have a spherical balloon. I think it must be where they use for the reliant balloons for the aortic stent grafting.
Yeah,
it's a spherical balloon.
One of the balloons is the equalizer balloon that is available from the Boston Scientific, which is
actually that was no, that is. I mean, if you can get it, that's fine. But even I use a reliant balloon, which is a spherical balloon that will go through any toe sheath. It's fine. Even without sheath, we can put it through the skin. So those balloons are even, see, basically it is not the type of the balloon, according to me, which works. Which is any balloon, you can use it, but the balloon will give a support so that it will not prolapse. The device will not prolapse. It really doesn't matter which make you are using.
There are a few questions from Dr. Lokesh, Prashant and all. What do you define as flimsy margin? I think it is very difficult to answer and it is more subjective.
It's a more of a subjective, I would say, So that's why the most of the, even when you say flimsy rim.
What is the definition of a flimsy rim? I think operators have to decide on
yes.
these questions. There was a very interesting question from the jugular axis approach. Can we use a PDA delivery system which has got a better curve to make it face more towards the left pulmonary veins rather than trying to use an ASD sheath? The sheaths remain with the fixed curve only as long as it is outside in the pocket. But as soon as you take the entire device and the regular cable, the whole device, the whole sheath will get straightened out. But any thoughts of?
Absolutely. It's a good idea. In fact, we can get some sheet called crossover sheets. Small sheets are available. In fact, they are very shorter length also, 30 centimeter sheets for jugular. That's quite good enough. It's got, with it, flexor sheets. So they're quite good enough. I think that's a good idea. We can use those, the curved sheets, preformed curved sheets. You get it from
the JR, can I ask?
Yeah.
See, now over the period of time, I am sure that everybody changed the practice to use pulmonary vein technique rather than balloon-assisted technique.
Yes.
So, what are the major advantages? Still, you feel balloon-assisted technique will be superior than pulmonary vein technique? Because in our lab, I think in the last 1 year, we have done only a couple of occasions of balloon-assisted technique. And 90% of the times we even electively also switch over to the pulmonary vein technique. So I just want to know both of your experience, and JR can tell in what way BAT is superior than pulmonary vein.
No, you're right, Dr. Nageshwar Rao. I think the incidence even in our lab using the BAT technique has come down drastically. I would say that extremely low. But sometimes it has helped us to bail out the situation. In some very large, like 36, 38 millimeter, there is a very deficient IVC rim or some rim, anterosuperior rim. It has worked. When I have failed with using any of the RVPV technique or LVP technique, I think I would still go, last chance, I would take the help of a wire or a balloon at least, isn't it? So incidence has come down, but that particular technique will stay in some situations. Shiva, what's your thought?
Yeah, I would say probably last couple of years we have not used the balloon assisted technique at all. But I would say that as the pioneer is watching the show, we actually came through an era about 10 years ago where there were quite a significant number of procedural failures and the patients were taken into the cath lab. The procedure will be done and then we come out and tell the relatives very often that the ASD was very large and we could not achieve it. And it was during that time that Dr. Bharat proposed this balloon-assisted technique and it entirely changed the procedural success. So it's an evolution. Basically, as we started doing lots and lots of balloon-assisted techniques, we also started understanding a better three-dimensional perspective of each and every ASDs, how the device fashions itself with the left atrial disc in the left atrium, and over a period of time have adopted techniques wherein we don't have to take an additional femoral venous access. I think balloon-assisted technique was extremely sound in its principles. And as you said, the same thing applies to the wire resistance, the dilate resistance, but it actually helps a person to improve his perspective phenomenally. We have not used balloon-assisted technique in the last 2 to 3 years, I would say. Even when we use the largest 48mm device of Aclotech and the 46mm devices of Lifetech. There are some questions more. There was
Shiva, Bharat sir can start with the comments and he can switch over to his talk if it is okay.
So
Because
we are cutting
it
down.
is
There are about 6 or 7
12:55.
more questions that are
We
asked.
have a limited time. That's the reason why maybe you can initiate the discussion from Bharat sir with Bharat sir, and then he can start his presentation if it is okay with you.
Fine. Dr. Bharat, we welcome you.
Yeah, I think I heard all the comments and I completely agree with you. You know, this is all like a work in progress. You can't say that one technique is superior to the other technique. I think as you evolve, as Shiva very rightly said, probably newer techniques will come into being. Now, the only issue about the pulmonary venous technique, as I have described in one of our articles, there are two issues when it comes to improper deployment of the devices. It is either malalignment or there is a problem of accommodation, what I call as problem of alignment and problem of accommodation. I think the pulmonary venous techniques are extremely good when you are dealing with large ASDs in smaller children, because that's a problem of accommodation, and using a balloon doesn't help because balloon will occupy further space in the LA, and sometimes trying to engage the left atrial disc into one of the pulmonary veins or even into the left atrial appendage would make sense. Now, what are the issues with pulmonary venous engagement? One is that there may not be a spontaneous disengagement, in which case you may have to pull on the LA disc, and that may be sometimes catastrophic by injuring the pulmonary vein. We have also described a contrarian way of disengaging the disc by pushing on the cable rather than pulling. In doing so, you may sometimes knock on the AV node and cause AV conduction problems. Sometimes when you do these engagement techniques, there may be a premature disengagement of the device, as a result of which both the discs might fall through the defect. So there are issues even with pulmonary venous technique, but I agree with you, it is far more convenient as compared to using a balloon assist, which requires additional hardware and also an additional access. So I think you should choose a technique with which you are comfortable. The ultimate aim or the goal of the procedure is to get a successful outcome. So I take your point on that.
Just two questions before Dr. Bharat starts, because this question has come again and again. Number one is oval defect, where there is a difference between the maximum and minimum dimension. What is the age group at which you will choose the average? What is the age group at which you will choose the maximum? Dr. Jai?
No, what is the age group?
The question that came up 4 or 5 times here are oval defects, wherein there is a maximum dimension and a minimum dimension. How to choose the device?
No, I think once again it's difficult to completely give a proper answer for this.
What I follow in practice, the patient is an adult, then we try to take the maximum.
Yeah, maximum, definitely maximum. But we should go by the maximum thing.
But if it is a small child, then you have to take something like an average and use your.
Yes, average, and see it becomes a problem if the child is less than 12 kilo to size the maximum size. So 12 kilo or 10 kilo, then it's a problem. I think if we try to take the maximum defect size, maybe the LA will get occupied and the issues are there. Probably you have to take the average in a child. For an adult, I think I would take probably the maximum size, which is possibly estimated on the transesophageal echo.
Shiva, can I make a 1-minute comment on this?
Sure. You're audible.
I worked on this problem along with the engineers in the Indian Institute of Technology by deriving by using a computational model and by using some of the mathematical formulae. If you know that for converting an oval into a circle, there is a correlationship of a major axis and minor axis with the diameter of the circle. This was described by one of our famous scientists, Mr. Ramanujan. And we used Ramanujan's equation to find out mathematically how we can get the diameter of the circle using the major and the minor axis. And then we used a computational model for comparing the mathematical derived these things along with the computational model. we found that there was a very good relationship between the model that, between the computational model and between the derived value using the mathematical formula. The only problem is that we were never able to validate this with either a three-dimensional in vivo measurements or with any kind of clinical correlationship. And that is where it stands today. But I think I'm willing to share this model as well as the mathematical equations with the people if they're interested in trying to take this study a little further.
True. The last question before I request Dr. Bharat Dalvi, there were many questions on what is called as the spiral septum or intratracheal septal malalignment, or the septums in which the septum primum and the septum secundum move apart from each other, leaving behind a gap between the two. So Jai Ranganath, how will you approach these patients, and what are the tricks that you have to achieve a successful closure?
The malaligned septum, is a very, very important issue, and then I think it is going to complicate the problem, definitely. If it is a truly very, very significantly malalignment, I would not attempt a device closure.
Thank you. Actually, there are many more questions, but as Dr. Nageshwar Rao, who is the final master, has told, we will go on to Dr. Bharat Dalvi for